Hi, everyone. I hope you got my message. I was running just a couple of minutes late. I'm so sorry. As you could probably see, I work from home. Today, I have a little commotion going on in the house, and it just took me a few minutes to address that. Hopefully, that's not going to be a problem for us during the presentation today. So I appreciate your patience and understanding. So let's get started. I just want to welcome everyone. I'm going to make sure I've got my recording going. I do. Okay, I think we're set. Welcome everyone to the Idaho-Washington Active Chapter webinar today on the role of the clinical documentation specialist in the management of clinical validation denials. And boy, you guys had a great turnout for this webinar today, so I'm glad to see you all here. My name is Denise Wilson, and I am going to be your host and your presenter today. I'll tell you a little bit about myself here shortly, but I am with the Association for Healthcare Denial and Appeal Management, and so it's also known as ADAM, so you might hear me talk about ADAM just a little bit today. Okay, if you're not familiar with GoToWebinar, you should have a little control panel that popped up on your screen that you can hide or unhide through this little red arrow here at the top. It will allow you to choose if you want to just listen through your computer audio or if you want to call in. Either way is fine. You can download the handouts for today's presentation under handouts. So please try going there first and downloading them. If you have trouble downloading them, which I know sometimes you do because you're at work and you're behind firewalls and whatever. If you're not able to download the handouts for today, you can put let us know in the questions area, okay, the questions area box that you're unable to download the handouts. Give us your email address. And I have Kristen on today. She's my co-pilot, and she will email you the handouts. She'll do her best to email you the handouts during the presentation today so you can have them to follow along. I also want to thank Susan, Sherry, and Jenny for inviting me to speak today. And they also have copies of the handouts, the PowerPoint slides for today as well. Susan Fleener, Sherry Young, and Jenny Beaumont. So I'm Denise Wilson, and I'm Senior Vice President at PayerWatch and Appeal Masters. I'm also President of the Association for Healthcare Denial and Appeal Management. And I've been in, I was reading over this morning, I've been in healthcare for over 30 years, and this year marks my 40th year of working in healthcare, but I don't know if I'm going to update that or not. I might just leave it as over 30 years. So I started out as a respiratory therapist and then as a nurse, worked in nursing, worked in cardiac, doing cardiac stress testing. About 17 years ago, I started working in denial and appeal management. And since that time, I've written hundreds and hundreds, probably 1,000 appeal letters. I've been in front of the administrative law judge hundreds of times. And today I do primarily a lot of education on denial and appeal management and also manage our association. So our association is the only association dedicated to healthcare denial and appeal management. We created this association about 2.5 years ago. We have about 500 members thus far, and it was really created to help support those folks in revenue cycle, in the hospital system, in physician offices, outpatient centers who have to deal with insurance denials, help support you with education, with networking, with understanding all the rules and regulations around writing appeals so that we can even out the playing field so that we know and play by the same rules that the payers do, so that we can be successful in making sure that our providers are getting paid fairly and equitably for the services they provide to patients. And the association was created through the generous support of PayerWatch, which Appeal Masters is part of, and that's where I kind of got my start in appeal writing. For continuing education, continuing education will be emailed out to you all within the week after the webinar for those who attend the full hour. So please make sure you stay on till the end of the hour. Our GoToWebinar platform will provide us with a report of everyone who's been on and how long you stayed on. So I will be supplying that to Susan, Sherry, and Jenny so that they can then go ahead and get your CEs emailed out to you. So we're going to start off today with a survey. I'm really excited about this. We don't do surveys very often in our webinars. So I've got 3 questions for you all, and I've got to pull up a little. Okay, somebody said the slides aren't advancing. Let me make sure I don't have them. You're right, they are not. I'm so sorry. I had them stopped earlier. Okay, let me just go. Do I need to go back? Let me look. I don't think so, because I really was just talking about the association. So I think we're good. Picture of me. And then here is your how to access the little control panel if you're new to GoToWebinar. So thank you for letting me know the slides weren't advancing. Okay, so let's do our poll. So the coordinators supplied me with 3 questions to pull up on the polls. I'm going to give you about a minute, maybe a little shy of a minute, to answer each one. You can answer it on your screen. You should be able to just click on your screen and it will record your answers. And I'm really interested to find out the answers to these questions as well. I think it'll be interesting to understand if you're currently working in appeals in clinical validation, or if you are, and what your experience has been. Okay, so I'm going to go ahead and launch the first poll. Okay, so it is your CVI department currently involved in writing clinical validation appeals? And Susan, Sherry, and Jenny, I'll just let you know, you might want to do, when I show the results, you might want to do like a quick screenshot or a picture of the results, because the results show up in a nice little graph, which I think when I send you the results out of GoToWebinar, it won't be in a nice graph form the way that you're going to see it here in just a minute. So like I said, you might want to just take a little picture of it if you have the ability to do that. Okay, it looks like we've got some answers still coming in. I'll wait just a second. Okay, let's go ahead and close that poll and let me share the results. Okay, so 37% regularly, 28% sometimes, 14% rarely, 22% never. That's interesting. Okay, let's go on to our second question. This one I'm going to go ahead and launch that, but I'm also going to read it out to you. Our system only let me put part of the question in. It had a limit on the number of words I could put in there for the full question. So the full question is, if your CDI department is involved with appeal writing, do you get feedback as to overturning of the appeals that you assisted with? If your CDI department is involved with appeal writing, do you get feedback as to your overturns for those cases that you assisted with, or those cases that you, of the appeals that you assisted with? So obviously if your CDI department is not involved in appeal writing, then this would not apply for you. Okay, Let's close that one, look at the results. So regularly, sometimes, rarely, never. It's kind of spread out across the whole gamut of responses there. Okay, we've got one more question. And this one again is not, the full question does not show up here. So let me read you the entire question. So if you are involved with appeals and you do get feedback about them, does your department provide education back to the providers regarding the appeals win, won, or lost? Appeals win, loss. So if you do appeals and you get feedback about them, then do you then share that with the providers regarding the wins and losses? Interesting. Okay, let's close that one out. Share the results. This is really interesting. You guys are very stingy. You're not sharing. 30% never share. Okay. Really interesting results. All right, let's hide. I'm going to stop the polling now, go back to our presentation. Just to make sure that you guys are seeing. Yes, it looks like you're seeing my screen. Okay, very good. Thank you so much for those poll results. I think your ACDIS chapter is going to find that interesting. I found that interesting, just hearing from you about that. So let's get into the education. Our objectives for today is describing how CDS are a natural fit for managing denials and authoring appeals, explaining how to establish clinical guidelines, which is, what is used to help prevent and manage denials for clinical validation, and then how to write a valid argument to support a clinical diagnosis entered in the medical record. So I was going back when I was looking at this presentation. I haven't given it for a little while, so I always go back and refresh and update them when I get asked to do on a certain topic. And the first time I talked about this was 4 years ago. The first time I gave this presentation was 4 years ago at an ACDIS conference, local chapter conference in Baltimore. And at that time, it was a relatively new concept, I think, to have CDI involved in appeals. But to me, it was just really a natural fit that folks who have that kind of education, that experience, that knowledge are going to be a perfect fit for appealing clinical validation denial. So let's start off with just a little bit. I like to start kind of with the basics and then move on. So the ACDIS, I was looking at the ACDIS position paper of defining a CDI specialist roles and responsibilities. And number one was complete and accurate diagnostic procedural coded data necessary for many reasons, including accurate reimbursement. Well, that's exactly what we're talking about when we're talking about, clinical validation and making sure that we're not getting denied for diagnoses that aren't clinically supported, and making sure that payers are getting their accurate reimbursement. So CDIS serves as an essential resource to the clinical team, ensuring that all the relevant conditions requiring hospital resources are being accurately captured in the final coded data, and to ensure that documentation and health record contains critical elements. You have to apply broad clinical and coding knowledge base to discern relevant clinical conditions. So CDIS facilitates modifications to clinical documentation through, and I thought this was interesting, through concurrent pre-bill interaction with providers and other members of the healthcare team. So when we're talking about denials and appeals, of course, we're talking about, it's not going to be pre-bill, it's going to be typically post-bill. It is going to be post-bill, post-claim drop, audits, and denials. that you're going to be addressing through the appeals process. And I don't see that in the ACDIS position paper, and I think it's time that I have a conversation with ACDIS, the home office, and say, let's get this updated to include folks who are working in the appeals process. CDIs will clinically evaluate how the health record translates into coded data, including clinical documentation, lab results, diagnostic information, and treatment plans. Okay, none of that was probably new information for you all. So let's talk about insurance claim denials, especially if you're not involved in them right now, just to kind of, paint the landscape here of what we're talking about. So I just included 4 types of insurance claim denials here because there's a lot of other ones that we can talk about as well, but these are the 4 main ones that anyone who's working in denial and appeal management, these are the main ones that we address. Okay, medical necessity, which talks about hospital status, medical necessity procedures or services or readmissions. Coding, you all may be a little bit familiar with. Coding of principal, secondary diagnoses, procedures, and other coding issues. Technical denials are things like the billing office sent in a duplicate claim or used an incorrect modifier. Those can sometimes be appealed as well. Or clinical validation, that's one we're going to talk about today. And then clinical validation asks the question of whether the documented clinical indicators in the medical records support the diagnoses that were placed on the claim. So that's kind of the basis for clinical validation. So this definition of clinical validation came from the 2011 Recovery Audit Contractor Statement of Work. So the Recovery Audit Contractor is an auditor for traditional Medicare. And in 2011, this is really the first time I saw the terminology clinical validation. And what they described in their statement of work was clinical validation is a process which involves a clinical review of the case to see whether or not the patient truly possesses the conditions that were documented. And I kind of take a little offense at the way that's written, because how does someone who's looking at a medical record know whether a patient truly possessed the conditions that were documented if they weren't at the bedside evaluating and assessing and treating that patient? So I think they could have worded it a little bit differently. But basically what they're saying is they want to make sure that when a diagnosis is on a claim for a patient who's been hospitalized, is there clinical support for that diagnosis? So because of the mix of clinical and coding knowledge that CDS has, professionals in that arena are a natural fit for managing and helping to prevent clinical validation denials and being successful in writing appeal arguments and getting those denials overturned. So I'm going to talk a little bit about prevention, clinical validation denial prevention, and also about successful appeals once you do receive a denial. I had another thought on that, but I can't remember what it was right now. Maybe it'll come back to me. Okay. So some of the high risk, I was going to say that clinical validation denials are like almost very, very close to a very, very close second to medical necessity denials. Okay, so medical necessity denials for necessity services and whether or not the patient should have been in inpatient status are still the #1 denial that we're seeing coming out of hospitals, but clinical validation is now a close second. So I think that's just going to continue to grow. And that's for a number of reasons, which I'm not going to get into today. But I just think it's, if you're not doing it now, it's something you should think about getting involved in, because it's definitely going to keep you busy and keep you in the business for sure. So some of the more frequently seen diagnoses that are being denied for clinical validation are sepsis, acute kidney failure, injury, respiratory failure, pneumonia, malnutrition, acute blood loss, anemia, encephalopathy, and heart failure. So, of course, the diagnoses that they're going to go after are going to be CCs or MCCs, because removing one of those off of, or multiples of those off the claim is going to result in typically in a lower weighted DRG and less payment to the hospital. So the payer is going to get some money back if they can challenge one of these diagnoses, take it off the claim, resulting in a lower weighted DRG. They get a few $1,000s back for those. So the other reason we see a lot of these as well is these are ones that are typically, a lot of these have like multiple ways that they are defined, clinically defined in their evaluations. There's different ways for diagnosing malnutrition, different ways for diagnosing acute kidney failure. We're going to talk about that a little bit today. So not only are these CCs and MCCs, but they're also can be a little bit nebulous as far as what clinical indicators support these particular diagnoses. And then these are some that we see, but not as commonly. So if you are in the denial and appeal management part of the revenue cycle, it would behoove you to create some appeal letter argument templates to use if you haven't done that up to this point, for at least the ones that are most commonly seen or frequently seen. Okay, so there's a couple articles that came out just fortuitously in the Journal of AHIMA in 2018, right before I gave this talk for the first time. I was already in the development of this talk when these articles came out, and I thought they were great as far as helping to understand, clinical validation. So in this article, the author said, clinical validation audits determine whether diagnoses documented in the patient's record are substantiated by clinical criteria generally accepted by the medical community. And I thought that was a much better definition of clinical validation audits. What we're looking for are there clinical indicators in the medical record that are accepted in the medical community? So what is generally accepted in the medical community? So that raises the question, whose clinical criteria standards do you follow? I'm going to talk about that a little bit as well. How do you determine what's a good clinical criteria standard to use in your appeal argument? And then the other article came out in the same issue of Journal of AHIMA, talked about when you're talking about clinical validation denials, there's a strong need to answer the following questions. Although the answers were not currently evident, and these answers still aren't, a lot of these are still kind of up in the air, in my opinion. Who is the best able to determine the clinical criteria used by both insurers and providers? I mean, is there one national standard that we should be using to determine clinical validation, and which standards are accurate? And so the one the biggie that we have dealt with, at least at Appeal Masters over the last several years, has been sepsis. Since the sepsis 3 criteria came out, every payer is out there denying sepsis if they don't see the sepsis 3 criteria used in the medical record, if they don't see that support in the medical record. And so that has been a really high volume, and it's also been a tough one to push back on with the payers. But there's others as well that we have a lot of problems getting the payers to kind of understand that it's a nationally recognized by the medical profession clinical criteria, and so it should be accepted to support that particular diagnosis. So how do you go about establishing or determining what are the generally accepted clinical standards that you're going to use in your appeal work, that you're going to use or educate your providers with, to make sure providers are using evidence-based medicine to establish definitions of diagnoses, and making sure that you're thinking about and including other disciplines when needed, such as, referring to dietitians, because your dietitian's involved if you're talking about supporting malnutrition. What's the best evidence, most current evidence out there now that helps support a diagnosis of malnutrition. Now, I know some providers have determined, like hospital-wide or system-wide, this is a standard that we're going to use for definition of sepsis. This is a standard we're going to use for definition of malnutrition or kidney failure. And they have something in writing, and you can use that as part of your support for a denial. You can go back to the payer and say, look, our hospital has determined this is how we diagnose, these are the criteria we use to support a diagnosis of this, or this. And I've heard there has been some success with that, and I've heard that there's been no success with that. So if you haven't tried it, it might be worth a try. But I will say it's probably not going to be, it's not like a gold nugget that's going to for sure help you get your denied cases paid. Okay, just checking over questions every once in a while, keeping an eye on those. So preventing clinical validation denial. So there is great value in using queries to physicians when a diagnosis is documented, but you can't see where there's where it has met any generally accepted clinical criteria. If we go back to the HEMA guidelines, they say it's appropriate to query when it appears a documented diagnosis is not clinically supported. So, of course, it's practice that a HEMA supports. CDS management should be meeting with physician groups, medical department heads, individual doctors, et cetera, explain why those questions are being asked, why are you querying them, and showing them actual denial letters can be eye-opening to most docs. So I thought that was interesting when during the poll, a lot of you said you're not sharing your results. So that was an interesting response to me. As far as querying, concurrent querying is best, but after discharge and prior to billing is the next best if you can't get it done concurrently. Think about having CDS review high dollar frequent flyer cases or your cases with the 1 CC or 1 MCC cases for clinical validation after discharge, but before you bill it. So that can help prevent the clinical validation denials from occurring. Even if you reviewed it concurrently, it's not a bad idea to look at it again before it gets billed. You need to go beyond looking for CCs or MCCs. You need to be familiar with commonly used criteria for the diagnoses when you're using your skills as a CDS, even if that means uncapturing a diagnosis that cannot be clinically supported. And that happens, and you're going to find it. We find it when we're writing appeals. Sometimes the diagnosis makes it onto the claim, and it isn't clinically supported. So it's not like the payers are always wrong. They're not always wrong. So even if it meets all coding requirements to code, it may not meet clinical validation criteria. Okay, and let's talk about appeal arguments, best practice in writing your appeals, and then I'll go through a couple of case studies because I know everybody loves to see, what's going on in the world. Everybody enjoys learning from case studies. So when you're thinking about appealing clinical validation denials, you can employ clinical indication standards from physician or disease specialty groups. So we're going to talk about that, like KDIGO. We're going to talk about, I know you guys are probably all familiar with Pinson and Tang. They publish a lot of clinical validation. I think they have a book that they put out every year. So that's what I'm talking about when you're looking at physician or disease specialty groups that publish standards for diagnosing particular disease states. Exploit the notion that there is no single gold standard for diagnosing some disease. Some diseases you can say, okay, I did a blood test, yes, you got it. You got this disease or whatever. But a lot of these have a set of different clinical indicators that you want to look at to help you determine, is it pneumonia, is it not pneumonia? So there may be, a patient may be exhibiting 3 or 4 out of 5 criteria that the pulmonologists of the world might say as the criteria for diagnosing pneumonia, they don't have to have all 5 of them. Sometimes they only have to have 2 or 3, but there's strong enough suspicion from the physician. It's still his decision making on diagnosing, for him to diagnose that that patient does have pneumonia. And then the whole sepsis 2, sepsis 3 is a perfect example of no single gold standard for diagnosing some diseases. And sepsis is really not a disease as much as it is a, what I want to say, it's a, I won't be able to think of the word now. It's a group of signs and symptoms. I know that's not the right word. I'll just say that. Acknowledge and verbalize in your appeal that every person or patient is unique in their physical makeup. So not everybody's going to present with the same severity or same types of signs and symptoms as the person in the next bed with the same diagnosis. And then what's really important too is don't forget to refute any payer incorrect statements regarding the record. So we see this a lot. The payer will say one thing in the record and it's absolutely not correct because, hypoxia was recorded in the record, or the patient did have a fever even though the payer says they didn't. So I think it's really important to make sure that you're refuting those statements in your argument to say the payer is wrong, because it just sets the expectation that if the payer is going to audit your record, they need to audit it thoroughly and completely and accurately and fairly. And just putting that argument back in your appeal letter allows you then, if you're seeing a record of or a pattern from payers who are constantly providing incorrect statements, it gives you a body of evidence that you can go back to the payer and file a complaint or have a discussion about not being treated fairly through their audit. Okay, so I have 2 clinical scenarios to share with you today as far as denials, and these are actual cases. Both of these got overturned. So the first clinical scenario, the original DRG was 638, the revised DRG was 639, and the code removed was N17.9, acute kidney failure, unspecified. The overpayment amount for this case was $5,235.20. So they can range, the overpayments on these range anywhere typically from about $2,000. They can be up to, I've seen some as high as, $18,000 or $20,000, just kind of depending on what they are looking at. So the denial rationale for this particular case for the acute renal failure was what the payer said was documentation was inconsistent or unclear regarding diagnosis of acute kidney failure. Even though acute kidney failure is documented, HMP and discharge summary supporting medical record documentation was not found within the record. And they go on to talk about the patient's creatinine, how it started at 1.47, and after fluids, it eventually ended up at 1.34. They also talk about how the patient was admitted to the ICU with D5.5 running, and their creatinine then improved to 1.26, and then it came down to 0.92. In the HMP, it stated acute renal failure. Creatinine baseline for this patient is around 0.9. It was currently at 1.4, likely from dehydration. And so the payer said the documentation supported the patient's creatinine improved with hydration. Now, one thing they did not say in this case was they did not refer to any acute renal failure clinical criteria that they were looking for to support the diagnosis. So it gets a little bit tricky sometimes in trying to determine what the payer is saying. Are they saying this should not be coded following coding guidelines, or are they saying this isn't clinically supported? And my advice is, if you're not sure they're denying it for coding reasons or clinical validation reasons, I would argue both, that it was appropriately coded and it was appropriately clinically supported. That way you're covering both bases. And we always, when we write our clinical validation appeals, we do always include a coding component to it as well to say that this was appropriately coded, okay, according to coding guidelines. So the appeal argument in the letter, this is put in a little table format because it just kind of makes it easy for the reviewer, the payer, whoever's reading your appeal, to understand where and how it was documented in the record. So we have the document source and the date. We have the pertinent information and copied exactly how it's written in the record. So it shows, hey, it was there if you had just looked for it. And then what page number that they can find it on. So again, trying to make it easy for your payer to rule in your favor and overturn the denial. Make it easy for them to find the supporting evidence. So yes, acute renal failure was documented one time in the admission history and physical, but acute kidney injury was documented several times, okay? In the hospitalist history and physical, it was in the critical care medicine inpatient progress notes. It was also in the discharge summary. So in the argument, back to the payer, number one, we always say licensed providers, including whichever provider saw the patient. In this case, it was a critical care medicine specialist responsible for the care of the patient, entered the diagnosis in medical records. So that's a coding thing, right? That has to be in there. That's how it's done before you can code it. As a term, acute kidney injury encompasses all stages of AKI, including pre-renal, acute renal failure, and acute tubular necrosis. So the documentation of AKI really encompasses not the diagnosis of the acute renal failure. There are many different clinical algorithms that purport to define renal diagnoses, and it's up to the individual physician to determine which criteria are appropriate for the individual patient circumstances. So that takes into account, one, there may not be one gold standard that defines a renal diagnosis, and every patient is an individual with different circumstances, okay? So that covers kind of those two concepts. Going on to point out that the auditor made a mistake when they said that the medical record did not support the diagnosis. So AKI was well documented to be the acute renal condition suffered by the patient. Now, acute renal failure and acute kidney injury are not the same on a clinical basis. There's different sets of clinical criteria for each diagnosis, and one cannot be used to validate the other or formulate a diagnosis of the other one. But despite differences on a clinical level, acute kidney injury, acute renal failure, both map to the same code, N179, which is labeled acute kidney failure. So we're kind of walking the payer through why it was appropriate and how it was clinically supported to have this on the claim. And then here's our evidence-based medicine standard, okay? So it's always important to include that as well, to say, look, according to KDIGO, for AKI, an increase in serum creatinine to greater than 1.5 times baseline, known or presumed to have occurred within the prior 7 days, is one of the 3 criteria that can be used to diagnose AKI. Okay, so we've got the three of them there, and we bolded the one that applies to this particular case. So when you think about it, with 0.9 and 1.5 times that, if you do your math, which I did, is 1.35, and his was as high as 1.4. He met that criteria. Okay, so I thought that was a really good example of how to successfully overturn these denials. So here's our second one. I like this one for a couple reasons. One is because it's respiratory, and that's a little bit of my background, but we see this all the time. And so I really want to make sure you guys get exposed to it if you haven't already. So original DRG was 193. It was revised to 194 by the payer. They took out, or they replaced, acute and chronic respiratory failure with hypoxia with just chronic respiratory failure with hypoxia, and this one was a little over $2,000 for the overpayment. So the payer said the patient's oxygen saturation was 86%. Doesn't say on room air, but it was on room air, but they don't say that in their rationale. They go on to say that the patient's oxygen saturations were maintained in the 90s with low flow nasal oxygen on admission. That's wrong, and we're going to point that out to them. And then they go on to cite a 1988 coding clinic, which says acute respiratory failure implies a PO2 of less than 60, which would be your hypoxic respiratory failure, or a PCO2 of greater than 50, which would be your hypercapnic respiratory failure. And they go on to say there's no arterial blood gas results, which document carbon dioxide levels greater than 50 or oxygen levels less than 60. Well, we don't do ABGs on every single dyspneic person anymore. Yes, we used to do them a lot, years and years ago. Now we have full oximetry. We just don't go around getting arterial blood gases on patients. It's very painful. They're kind of dangerous sometimes, and when you're talking about sticking needles in arteries, and they're just not necessary a lot of the time. The payer went on to say that acute respiratory failure implies a life-threatening condition, not merely an extent of hypoxia in a patient that could be treated with low-flow nasal oxygen. The patient did not require aggressive respiratory support, such as bi-level positive airway pressure or intubation. Again, they did not refer to any acute respiratory failure clinical criteria that may have been used to issue the denial. Okay, so again, it's another tricky one. Okay, I thought I skipped a slide there. All right, so here's our little table again. I know this is a little bit smaller print, but with the handouts, hopefully you should be able to see it without too much trouble. So it was a 62-year-old male who came into the ED for continued shortness of breath. He'd been in the hospital for COVID, pneumonia. He went home without oxygen. He came back in moderate distress, had coarse breath sounds, and the impression was hypoxia, acute respiratory failure with hypoxia. That was on 12/21. On 12/23, he had, they diagnosed him with acute on chronic hypoxic respiratory failure, which was worsening, and he remained on a high flow nasal cannula at 40 liters, 75%. I don't know why that says in room, 40 liters, 75% oxygen, so I should say. And he stated dyspnea not improved. So acute on chronic respiratory failure improved on 12/25. He was now down to 30 liters, which is 35% oxygen. And then on 12/28 in the discharge summary, they again reiterated acute respiratory failure with hypoxia, and he went home on 1 liter of oxygen. So lots of good supporting documentation from the diagnosing physician. The test results, he actually did have an ABG done, so I did include that. And sure enough, the PaO2 shows 92. It's not less than 60, but guess what? He's on 80% oxygen when they drew it. He had a high respiratory rate, and then his pulse oximetry on multiple occasions supported the hypoxia, even though he was on oxygen at the time. So our argument back was that the clinical information the payer used to refute this very well-documented diagnosis of respiratory failure came from the coding clinic, and that is not to be used to assist a coder to understand clinical situations. It's not to confirm or refute a diagnosis made by a licensed provider. So we see that all the time. They're not supposed to be using those as their clinical validator, that we see it all the time in denial. They also said that there were insufficient findings to justify the diagnosis on admission, but we explained to them that the information in the medical record is consistent with evidence-based guidelines for establishing that diagnosis. The patient presented to the hospital in moderate distress with shortness of breath. In the ED, his room air oxygen saturation was 86%, and he was treated with oxygen up to 100% via mask. And these findings are diagnostic of acute respiratory failure. So the evidence-based guidelines to define acute respiratory failure are, and these came from Pinson and Tang, I believe, a PO2 of less than 60, an FPO2, which is what we use most often these days, of less than 91% breathing room air. And of course, this guy had an 86% on room air, 88% on 15 liters. A PF ratio less than 300, and I'm not going to talk about PF ratios, that's a whole nother topic. PO2 decrease or PCO2 increase by 10 millimeters from baseline. Well, we don't really know his baseline, but we do know he was not on oxygen at home. The auditor also said he did not require aggressive respiratory support, such as BiPAP or intubation, and our response is that it was disturbing that the auditor does not consider a patient requiring 100% oxygen as aggressive respiratory support. There's no minimum level of oxygen required to establish a diagnosis, and imposing an oxygen requirement would directly conflict with coding clinics regarding documentation of acute respiratory failure. And of course, the need for ventilation, BiPAP, intubation, mechanical ventilation are not required to establish the diagnosis. Regarding their statement that the ABG did not reflect CO2 levels greater than 50 or oxygen levels less than 60, the patient was on 80% oxygen at the time the ABG was drawn. Per medical literature, pulse ox is acceptable to establish a patient's oxygen saturation, and with the invention and widespread use of pulse oxes, EBGs are not required these days. And then here is our reference to the evidence-based clinical guideline that supports the arguments that we made in our appeal. Okay, and this is just the second part of that reference. I couldn't fit it all on one slide. So what we do is just kind of, we have this built into our template, and we just bold the pieces that are pertinent to this particular case. Okay, so to summarize, and then we'll get to some questions. Providers should use evidence-based medicine to establish your definition of diagnoses. The CDS should work with physician specialists to find clinical evidence that supports certain diagnoses and include other disciplines when needed, such as dietitians for support of malnutrition. When you're appealing clinical validation denial, and then also using your queries, I should have added that in there, to help prevent the denials as well, and looking at your bills before they get, your claims before they get dropped. For appealing clinical validation denials, employing clinical education standards from physician or disease specialty groups, exploring the notion there may not be one gold standard for every diagnosis, acknowledging and verbalizing every patient is unique in their physical makeup, and sometimes, you know, they may not come in with every sign and symptom. They may be on things at home, like maybe they just took a bunch of aspirin before they came in, and so they don't have a fever. Doesn't mean that they don't have an infection. Refute any payer incorrect statements regarding what's in the medical record. And then I did include the references to the articles that I talked about. The 2011 RAC Statement of Work is no longer available online. I have a copy of it, but you can't get it online anymore. And I don't think I should have put the Pinson and Tang on here, and I didn't. But there's all the rest of them. All right, again, I want to thank Susan Fleener and Jenny Beaumont. I think I said Beaumont earlier, and Sherry Young for inviting me to speak today. If you have questions afterwards, you can reach me at denise@adam.org. If you're not a member of our association, I would invite you to join. It's $125 for an annual membership, but we also have discounted group membership. So if you have a group of 3 to 20 or more people at your organization that you'd like to join, we do offer group discounts as well. Let's get to the questions. Okay, give me just a second to kind of expand that little box large enough for me to read your questions, and I'll see what I can answer. If I don't get to your question, I will do the best I can to send the answers to the folks who have supported, to Susan, Jenny, and Sherry to share with you. Let me make these a little bigger. And let's see. Okay, thank you, Susan. Dysregulated response when I was talking about sepsis, and I couldn't think of the words. Thank you for giving me your input there. What authority do the payers have to impose their own criteria for a claim? For example, the sepsis 3 criteria. That's a really good question. Some of it has to do with the fact that they really don't. I don't think there's any regulation out there from any insurance, Department of Insurance or insurance, healthcare insurance regulator that restricts payers from imposing their own criteria for a claim, except for sepsis 3. Speaking of sepsis, for sepsis 3, sepsis 2, there are 4 states in the country. New York is really leading the way. New York has a law on the books in the state of New York that says sepsis 2 is sepsis. So they came out right away and said, we're not allowing payers to use sepsis 3 criteria to, in denial for payment for sepsis care. And it all has to come down to, making sure that for sepsis cases that sepsis is being recognized and treated early in the process and not waiting until they are really sick and meet the sepsis 3 criteria before we call it sepsis. So it's Illinois, I believe it's Illinois, Wisconsin, I believe Ohio and New York, I think, are the 4 states that actually have it, have some process in place that says they are not in favor of payers using their own criteria. But otherwise, they can pretty much use whatever criteria they want to. I mean, I don't think there's anything out there that's regulating that or saying they can't do it. And someone said, and the person who asked that question went on to say, a facility or a payer may require that a physician use a particular clinical definition or set of criteria when establishing a diagnosis. That is a clinical issue outside the coding system. Okay, what is an expected or average overturn rate for successful clinical validation appeals, CDF? People ask this question of me all the time as far as, what should I expect for my overturn rate? And really, I see higher overturn rates in my experience for clinical validation than I do for medical necessity. Medical necessity is tough to prove a lot of times, it's tough to argue inpatient versus outpatient, but clinical validation is it's a little bit more of a black and white issue. And with a well-crafted argument, as long as the documentation is there to support it, you should have good success. So I would say, I'm just going to throw a number out there. Please don't quote me or hold me to this, but I would say 60 to 80% overturn is pretty good for clinical validation denials. So medical necessity, a little bit less than that, typically is what we see. But clinical validation, the payers, we just see so many payers who get it wrong that, that's kind of been my experience. Okay, we're coming up on the end of the hour. I'm going to stay on for a little bit. If any of you want to stay on, I'm going to stay on for a little bit and answer some more of these questions. I know a lot of you probably need to jump off because you're in the middle of your work day, but I will stay on for a little bit longer. Okay, and some of these are a little bit more in depth, so I'm going to skip over the questions and hopefully I'll get back to you with a specific answer. Yeah. So someone's asking about the step 3, step 2, having recent sepsis denial cases based on the payer's criteria of sepsis 3 definition, but your hospital uses step 2 in your coding guidelines. So again, that comes down to, we argue there isn't, step 3 still isn't universally accepted by a lot of hospitals, by a lot of physicians on how they diagnose sepsis 3. And I do want to point you to PayerWatch just did a 3-webinar series on sepsis. You can find the recordings for free I believe they're on our ADAM website. They're definitely on the PayerWatch website, www.payerwatch.com. Free to watch, really good, a lot of information from hospitals, 3 different hospitals around the country who talk to us about, their physician advisors talk to us about how they're battling step 3, step 2 denials. So I would encourage you to read those if that's something that's happening at your organization, which I'm sure it is. Okay. Sometimes payers will deny based on contractual agreements that it has been impossible for the CDI department to get a hold of any payer contracts. You are not alone. How would you advise going about getting that information from your organization? If I had the key to that, I would certainly share it with you. I hear that all the time as well, that there may be something in your contract that says the payer uses that. If it's in your contract, that means your hospital's agreed that they're going to agree to only get paid when it's step 3, or we agree we'll only get paid if you're using KDIGO or if it meets, whatever. So I have some ideas, or my own thoughts about that is, if you want to put it in your contract, that's fine. But you're going to need to accept the fact that you're going to have cases that you're not going to get paid for because, there's going to be physicians who aren't following that particular guideline. So you're kind of boxing yourself in the corner a little bit. But on the other hand, if you do have that in your contract, then it does kind of cut down on whether, are you going to, have as much appeal work that you have to do, because you've already settled on what the diagnosis is going to be. And if you teach your physicians to use that criteria, and if they use that criteria consistently, then yeah, you could cut down on some of your denials and do some prevention. So I know some hospitals have talked about doing it. I haven't talked to any hospitals who have said they've done it and it's been a boon for them or been very successful for them. That's just been my experience. Okay, someone said they complete denial rebuttals in a pediatric facility, but a lot of the appeals are based on the fact that denial is around adult criteria. This person responds by providing pediatric criteria, showing how that was met. You have one payer who continuously upholds the denial despite very clear appeals with clear clinical pediatric evidence. It seems to go essentially unread. I agree with you. You kind of wonder sometimes if anybody's even reading your appeals on the other side. What recourse do you have? It feels like they just get to keep saying no and treating all our toddlers as 64-year-old men when it comes to clinical validation. So this speaks to getting your appeals outside the court of the payer's opinion. So getting them to an external review agency, getting them to an independent review entity, taking them to the ALJ if it's traditional Medicare. And we have some webinars on that as well. So depending on your state laws, depending on whether you're appealing by provider, appealing by patient, depending on the appeal type, there's different opportunities to, after you've completed the internal appeal process, which is the appeals back to the payer, you may have an opportunity then to take it further and go to external review. You may have to file on behalf of the patient to do that rather than filing as a provider. So really, you kind of got to start with what does your state Department of Insurance say about it? what do your contracts say, who is the payer, what are the payer's rules and regulations, and those options. But then you can always file a complaint with the payer, and you can always bring it up if you have joint operating committee meetings with the payers, or bring it up to your managed care department to push back that way as well. Okay. Okay. So I think I answered all the questions, except there's a couple of them that are a little bit more in depth. So I want to take a closer look at those, and if I can come up with a good question for that. Okay. Somebody's letting me know my audio wasn't very good. Good. I do appreciate that feedback, and I will try to work on that going forward. All right, so thank you, everyone. Again, really happy that you all asked me to present today. If you do need a speaker at any time for anything to do with denials and appeals management, let me know. It's something I do a lot of these days, so I'm happy to help you out. Thanks, everybody. Have a great holiday. Have a great rest of your week, and have a happy New Year.